right, well, I have 8 o'clock on my computer. Michael, don't go away yet.
Just closing the door. Didn't want the cat to come in.
Well, I want to welcome everybody. This is our second iteration of medical grand rounds in the times of COVID. I appreciate everybody's flexibility. We are really pushing the boundaries of our technological expertise, and this is a new format, even from last week, where we have multiple different sites logging into this as panelists. So one, I wanted to just tell everybody and thank everybody who's on the call, who's on the grand rounds and listening remotely. Just appreciate all of your work and efforts during this time. It is challenging and unprecedented in our medical lifetimes, and I really appreciate all of the support that everybody's giving to each other and to our patients, and I hope everyone stays healthy and safe. And with that, I am delighted today. Oh, before we get to the introductions, just a few technical issues. If you have questions, and I hope you do, please try to use the Q&A slot. That is, if you go to the bottom of your WebEx, there should be a panel and there should be 3 little dots, ... If you click on that, you should get, you should see the icon for Q&A, and that'll open up the panel and you can type in your questions. If you can't figure that out, there is chat mode also, and I would recommend I would send to all panelists rather than all participants. But we're trying to funnel the questions into the Q&A panel. Worst case, you can always email or text myself or Clint, but we're really trying to encourage that. We have all of the participants muted per Clint, so thank you very much. And with that, I will first introduce Dr. Michael Lucy, who is the Division Chief of GI, to introduce our grand round speaker today, Dr. Erin Spengler. So Dr. Lucy.
Thank you very much, Lynn. Good morning. It gives me great pleasure to introduce Dr. Erin Spengler, one of our own faculty from the Division of Gastroenterology and Hepatology, as our Department of Medicine grand round speaker today. Erin received her undergraduate education from Augustana College, Rock Island, Illinois, in 2005, and in 2009 her medical degree from the University of Iowa. She stayed in Iowa for the next 6 years, completing her residency in internal medicine and then fellowship in gastroenterology. In 2015, she undertook a further year of advanced training in hepatology with a fellowship in transplant hepatology at the University of Michigan in Ann Arbor. Therefore, she's triple boarded in internal medicine, gastroenterology, and transplant hepatology. In 2016, we were fortunate to recruit Erin to our division as assistant professor in the clinical health sciences track. Erin has broad interests in clinical practice and clinical translational research. Her scholarly work stems from her daily clinical practice, and she is a gifted mentor of residents, fellows, and junior faculty. Erin has co-authored 10 peer-reviewed papers, 8 as first author, and 2 chapters. She's an active member of several multi-center groups, including the Liver and Intestines Committee, Intestines Community of Practice, I should say, of the American Society of Transplantation. Indeed, Erin or her mentees were due to give several presentations at the 2020 Digestive Disease Week and at the 2020 American Transplant Congress, both of which have had to be cancelled. Erin has a special interest in non-alcoholic liver disease. Together with Dr. Michael Guerin in the Department of Surgery and Dr. Sam Pavic in the Division of Endocrinology, Erin is integral to a proposal for a UW Health multidisciplinary center for bariatric medicine and surgery, which we hope will get back on track after we are past the worst of the COVID-19 crisis. Today, Erin is going to lead us through her review of the nexus of metabolic syndrome, non-alcoholic fatty liver diseases, and liver transplantation. So it's with great pleasure I introduce my colleague, Dr. Erin Spengler.
Great. Thank you, Michael. Can you hear me okay?
Sure.
All right. So I'll try to move through here. Thank you for introducing me and having me speak here. And thank all of you for calling in. I know this is probably your 10th hour of WebEx meetings in the last week, and this is probably going to continue. So I appreciate you taking your time here. So as Michael mentioned, I'm going to be talking about the burden of obesity and liver transplant, how this intersects with NAFLD, and then thinking beyond NAFLD with obesity in this population. I have no financial disclosures, and I won't be talking about anything that's off-label. So my objectives, so upon completion of this lecture, I hope the participants will be able to describe current obesity trends in the United States and how these affect the liver transplant population, explain the effects of obesity on liver transplant outcomes, including peri-operative complications, graft loss, and death, and examine the UW experience as it relates to liver transplantation in patients with obesity. So the way I'm going to do this is going through some of the definitions of obesity and how this affects the population, go through the particular considerations in the pre, peri-operative, and post-transplant periods, and then look at our UW outcomes with obesity as well as weight loss options currently and in what we hope in the future. Now, if you see here on the right, you can see how obesity, NAFLD, and liver transplantation intersect. We're going to be focusing primarily on obesity and liver transplant, including those NAFLD patients that fall within this. So in case you've been under wrack for the last 10 years, obesity is a major health concern. Almost 40% of the US population is obese, and this unfortunately has continued to increase. This is particularly dismal in certain populations. So in Hispanics and non-Hispanic Black, that's almost 50% of the population that's affected. Unfortunately, this doesn't seem to be improving anytime soon, as we're seeing younger people come up, the 20 to 40-year-olds. So if you're under that 40-year-old, you're considered a young adult, is over a third obese at this point. And of course, obesity rates increase with age, and over 40% of middle-aged adults. And so again, this is likely to get worse before it gets better. In Wisconsin, we kind of joke about being the cheese and sausage state and that we have high rates of obesity, but we're actually kind of right in the middle nationally. So we're about the 23rd most obese state with obesity rates above 30%, up from less than 20% in 2000 and only less than 12% in 1990. So this has been just a dramatic increase. Probably all seen these kind of heat maps of where obesity is worst, particularly in the down south. And if you see, we're kind of in the middle here. So this obesity crisis is affecting all of our patients. So in every field, we're having to identify how obesity affects our fields, our treatment, and how we need to modify our care to deal with these changes. So this is no different in the liver transplant population. So we found that in 2017, at least 17% of patients who were listed for transplant had a BMI greater than 35. That doesn't include just obese, but looking at this class 2 obesity. This is the same for people who are undergoing liver transplant. The liver transplant recipients, if we look between 1988 and 1996, was about 20% with a BMI over 30. In 2000 to 2011, it's a third of patients that fall into this category. And if you look on the right, our OPT and SRTR data, and in case you're not in the transplant field, this is our big national data sets that all the data is recorded for liver transplant. It's not very granular, but it is very broad. And if you look at the brown line, you can see that there's a very steep curve, and those are the patients greater than 35 BMI. And so we're actually seeing that this population has the steepest curve, that this is increasing at the greatest rate. So BMI over 30, again, we're going up to about 36% of our transplanted population in 2017. But this interesting part is the BMI over 35, which is up to about 14% of patients who actually receive liver transplant. Again, the obesity is increasing in the general population, in our transplant listed population, as well as those who are undergoing transplant. So this has probably come up many times. BMI does not tell the whole story. You'll hear me talking about BMI quite a bit throughout this. There's all the classic limitations to BMI. If you look at the right, you can see two people that are the same weight, same height, so they'll be rated with the same BMI, and obviously that doesn't take into account the build of someone's body, the amount of muscle mass, changes in gender, or changes in muscle that occurs with age. But in the liver transplant population, this is even more limited. So as you probably know, taking care of any of these patients, they have very variable volume statuses. So when they looked at a study where they checked people's BMI before transplant and immediately post-op, so about a week after transplant when some of the excess volume has been removed, they found that almost a quarter, so 11 to 22%, were classified in a lower BMI class. So not just a lower BMI, but actually moving down an entire class. The volume status really complicates this, especially in patients with significant edema, anasarca, or ascites. The other issue is fat distribution. So in a study looking at 384 liver transplant recipients, they found that peripheral adiposity did not increase mortality, but that visceral adiposity was associated with changes in mortality. This is something that's obviously not captured with the BMI, but is obviously something a little more difficult to look at when we look at larger studies, since we aren't able as easily to collect this information, although that is something that's being researched. And then the last thing is sarcopenic obesity. So this is something that's affecting the general population as well, but this is particularly severe in the cirrhotic population because we have such significant cachexia. It's a catabolic state that causes muscle wasting. So in patients with obesity and cirrhosis, 30 to 42% are actually suffering from sarcopenic obesity, and this has some significant implications for outcomes in these patients. So then with all these limitations, why am I using BMI throughout this? Because the rest of the world is using BMI. So BMI is something that's easily obtainable, it's objective, it's reproducible, and it's something that is similar among transplant centers that can compare outcomes between these things. And so most of the studies still use BMI as a measure of obesity. So the other reason I'm going to be talking about BMI is that transplant centers currently are using this for cutoffs for liver transplant. So more than 50%, so even in 2017, about 85% of centers stated that they would not consider somebody for transplant if their BMI was greater than 40. And it still is more than 50% of centers who will not look at these patients. This is something that they're not correcting for ascites, for volume status. And so when we're looking at outcomes, we're using the same measure that people are using in their transplant centers. And hopefully by the end of this, I'll show you that BMI is a very imprecise measure of obesity. And that even when we look at obesity, we're really using it as a surrogate marker for obesity-related complications and comorbidities. So even if we were able to do a little bit better assessment and able to do a DEXA and look at fat, or a slice of CT scan to look at visceral versus peripheral adiposity. These are things that are associated with other things like diabetes and cardiac disorders, but it's not synonymous with this. So even obesity itself is really a surrogate. Here you see something I'll go through in pieces, but some of the ways that obesity affects the liver transplant population, peri-operatively, and post-transplant. This is something that really affects our care and what we deliver throughout this period. So we'll start with pre-liver transplant considerations. One of the first things we do when we evaluate patients for transplant is we look at some of their social factors that will come into play with their ability to take care of themselves, to take care of their transplant, and how we may modify those things to have better outcomes in the perioperative period and long term. And something that we need to think about with obesity is that there are a lot of social economic determinants. And if we aren't putting these into our plan, we're going to be disservicing our patients. So unfortunately, as socioeconomic status decreases, BMI tends to increase. And part of this is access to healthy food. So if you see below, I have pictures of fast food. It's a way that's very quick, easy. You can feed your whole family for not a lot of money. And on the left is a food pantry. And if you've ever tried to manage somebody with ascites who needs to be on a low sodium diet or cardiac disease, when people are getting their food from a food pantry, it makes it incredibly difficult because it's really limited what they have access to. So any weight loss plans that we have, pre-transplant, post-transplant, really needs to take into account these limitations. The other thing that we look at in all of our patients pre-transplant is frailty and malnutrition. And we actually have our dietitian, who's now 2 dietitians who are very fantastic, working with our liver transplant population, because this can actually really affect outcomes. Luckily, I'm hearing it less, but previously it was very frequent for people to say, you know, this patient couldn't have malnutrition, their BMI is 45. And that's not true, actually. I think people are recognizing this more, that obesity is the new form of malnutrition. And we find all of the typical factors with malnutrition and their poor outcomes in the population with obesity. And unfortunately, this also is associated with more frailty, as I'd spoken about with the sarcopenia. This is something we need to recognize in this population as well as in all patients and manage aggressively. Metabolic comorbidities, this is something that I think we have more of an eye on in the obese population. But again, this is something that is not specific to people with a certain BMI. All of us have taken care of patients who have a weight of 300 and they have no diabetes, and someone who's a normal weight who does have metabolic syndrome. So this is something we need to look at the actual patient, figure out what their comorbidities are, and be aggressively managing this in all patients. And this is something that our primary care colleagues are excellent with, and something that we really need their help with perioperatively post-transplant as well. And we'll go through pre-transplant weight loss at the end. So the cardiac evaluation is a little bit nebulous. So there are lots of excellent studies looking at the best way to screen people. And unfortunately, there's no consensus for all of this. There's some questions about the accuracy of non-invasive testing in patients with cirrhosis. This is even less clear in patients with cirrhosis and obesity due to chronotropic incompetence and compromised ventricular response. Invasive testing, such as left cardiac cath, continue to be very reproducible among different patients. So we recommend using actually the same guidelines that we use for other patients, which is basing on the number of cardiac risk factors. And that's what we do at UW. We go through any of their specific cardiac risk factors, and based on that, they're stratified to a certain model for cardiac testing. As we know, obesity can be associated with higher rates of diabetes and coronary disease, but we recommend not finding a BMI and basing cardiac workup on that, but actually looking at comorbidities. So this is what we do with our population. All of you do with your population. You don't see someone's BMI and send them for a cardiac cath or a stress test. You really base it on symptoms, comorbidities, because there's a lot of things that go into that, not just BMI. Well, the other thing is waitlist mortality. It's actually increased with BMI and with obesity. So if we look at the time to transplant for patients with obesity, we actually find that there's a longer time to transplant if people have a higher BMI. They're actually less likely to be transplanted overall and more likely to die on the wait list. And this has been shown in multiple different studies, and it's something that I think we need to work on research to address why this is happening, and then also discuss this with our patients that they may have a higher waitlist higher waitlist mortality. So one study looking at adjusted rates of liver transplant between 2002 and 2006 showed that in patients with a BMI of 35 to 40, they were 11% less likely to get a transplant. And for people with a BMI greater than 40, they were almost 30% less likely to get a transplant. This has been repeated in other more contemporary studies, looking at BMI greater than 40 compared to less than 30. And again, a higher waitlist mortality in the higher BMI patients. It's not exactly clear why this is. This is retrospective data, but we think that it's at least in part due to this lower probability of receiving MELD exception points. So for those who are not in the transplant field, everybody knows we're kind of listed according to the severity of disease, which is based on MELD. But some patients are able to get exception points due to hepatorenal syndrome, hepatopulmonary syndrome, and cancer. And people who have higher BMIs are actually less likely to have those points and to have higher organ turn down, probably in part related to size matching. And then the last thing is how frailty plays in with this pre-transplant. So I kind of alluded to this, that frailty and obesity tend to intersect and cause worse outcomes. Here's a graph that kind of goes through for all patients, looking at the waitlist mortality as it relates to frailty. If you look at patients with a BMI less than 30, they're about 1.5 times more likely to die on the list. If you go up to class 2 obesity, it's actually more than 3 times as likely to die on the list. So there's a big change when you combine frailty and obesity. So when we look at perioperative considerations, we'll go through things that are intraoperative as well as in the perioperative period, just immediately before or after transplant, usually during the hospital stay. So in the procedure, there's all the typical things that we deal with surgery and obesity. So there needs to be modification of anesthetic medications related to metabolism. There's difficulty a lot of times with airway management, difficult airways in this population. There can be difficulty with visualization in the surgical field related to visceral and central adiposity. The donor-recipient mismatching, as I mentioned, that this can cause small for size, but also means that it's a little bit harder to find a good match for someone who's very large. Problems with wound management, a little bit more likely to be open or have wound infections. And a couple of studies have shown that there's longer operative times, in part related to all these issues above, but no change in blood product administration. For perioperative outcomes, if we look at studies that are after 2000, they actually found some things are the same if people have a BMI greater than 35 or less than 25. So there's no change in primary graft function. This is a really important thing. It's a rare thing to have primary non-function, but this is not increased with higher BMI. Acute rejection episodes are not increased. There's no increase in vascular complications or need for immediate reoperation. There is, unfortunately, higher rates of wound infection, dehiscence, and overall infections. And this is looking at any of the studies after 2000. There's also increased length of stay, and this has again been shown with multiple different studies at different places. Looking at about 1,300 patients between 1994 and 2009, we found that about 72 patients, which were the only ones unfortunately in that BMI category over 35, had higher length of stay and ICU times. In a SRTR, which is again our overall database throughout the United States for transplant recipients that had a little bit more robust BMI over 40 group of 400, again found that ICU and hospital stays were longer in this population and that they were more likely to discharge to a SNF and rehab center. And this may be in part some of the things we talked about with frailty and its higher rates in obesity. So in the post-transplant period, we'll talk a little bit about weight gain as well as survival. The weight gain post-transplant, unfortunately, this is something that happens in just about everybody. It's actually more than 80% of patients will have weight gain, and this includes all BMI ranges. So people who are starting with a normal BMI are likely to gain weight as well. And this is because of a lot of things that kind of intersect in the post-transplant period. So one is the immunosuppressive regimens. Some of them can promote weight gain, and all of them can contribute to the metabolic complications. So at this point, there's no indication to tailor therapy because of this. And different studies that have looked at different regimens have not shown a difference in weight gain between the regimens. The medication that's most associated with weight gain in the postoperative period is prednisone. So this is something that we try to get people off of pretty quickly, and something that all of you have probably dealt with in a population of patients with obesity. The other thing is addiction transference or replacement. We obviously have a large population of patients with alcoholic liver disease, and we find that afterwards, a lot of patients who previously turned to alcohol for stress and comfort now turn to food. And so this population in general is at particularly high risk of weight gain and metabolic syndrome. And then the last thing is, this post-liver transplant metabolic syndrome is just incredibly prevalent, and not just in the obese population. So almost half of all liver transplant patients will fall into the metabolic syndrome definition by the time they're post-transplant, usually within a year. And so this is something that we really need to be working as a group with primary care doctors and transplant physicians, nutritionists, to try to change this so we can change long-term outcomes. Early referral to a nutritionist and dietary program is very helpful, or at least initially very helpful. We'll talk a little bit about how this works long-term, and then working hard to manage these complications. So here's a diagram that goes through, again, part of the reason why metabolic syndrome is so prevalent in this population. So it starts with this reversal of catabolic state. So patients tend to lose incredible amounts of lean body mass in the pre-transplant era. Basically, anybody who's developed decompensated cirrhosis. They have lower energy intake because they feel poorly, they have no appetite, they can't eat well, they have ascites. And most of them are actually eating much fewer calories that are needed to maintain their body weight prior to transplant. Afterwards, this is reversed. They have increased energy intake, and they tend to still have lower physical activity in the year after transplant. The other thing is this immune suppressive regimens. So with corticosteroids, we find all the typical things that can lead to metabolic syndrome. But this is also the case in the other medications that we use. I'll show you a graph next. So all of this leads to weight gain, precipitates this sarcopenia, or allows us to propagate. New onset diabetes is actually very common in addition to patients who had it pre-transplant. And we actually can find a worsening of patients previously diagnosed with diabetes after transplant, in part related to steroids and this really rapid weight gain. And then dyslipidemia and hypertension are ubiquitous in almost 100% of our patients. Some of the studies that look at over 85% in the first year that will have these complications. And obviously, as well as this causing post-transplant metabolic syndrome, it can also cause recurrent and, more importantly, de novo NAFLD. So again, when we're looking at this intersection between these three diseases, obesity, NAFLD, and patients with cirrhosis and a need for transplant, we find that there's a big increase because we have these same complications that have led to issues pre-transplant. And there's a whole new population of patients being transplanted for hepatitis C, PBC, autoimmune hepatitis, who are actually developing NAFLD in the post-transplant period because of these metabolic complications. And this can obviously lead to cardiovascular death, and is something important that we're addressing as we get better at taking care of these transplant patients for other means. This is a nice graph of what we look at in general with the medications that we use. These are the 4 most common immune suppression agents in the liver transplant population. If you look across, corticosteroids in the first row is associated with weight gain, new onset diabetes, dyslipidemia, and hypertension. And about 100% of our patients are on corticosteroids post-transplant in at least usually the first year. For dyslipidemia, you'll see that all of these medications can cause dyslipidemia. It's particularly bad in mTOR inhibitors, so that's things like sirolimus, which we use a little bit less than some of our other transplant colleagues. And then the other thing I wanted to note is really the only one that's associated with dramatic weight gain is corticosteroids. So tacrolimus and cyclosporin are felt to be more weight neutral. mTOR inhibitors may actually have weight loss. And so these medications alone are not what's causing this increase in weight. And this may be why we find these studies looking at different immune suppressive regimens do not change the rates of obesity post-transplant, because this is not the primary driver of weight gain, although it is a very major driver of metabolic comorbidities. So now probably the most important thing that I wanted to show you is the graft survival for patients, patient and graft survival. Because this is what we really care about. We really care that patients do well post-transplant, that they get to live a long, healthy life. This is why all of us are in transplant. So obviously, just like with the patients with alcoholic liver disease, we want to know that people are able to do well afterwards. So most of the studies that are out there are actually very small single center studies, and there's very few patients that fall into this BMI greater than 35, and even fewer with a BMI greater than 40. So interestingly, a lot of studies that people bring up when we give this, we've given an oral presentation of some of our research here, is studies that have 4 or 5 patients with BMI greater than 40. And so it's important when we're looking at these that we're actually looking at it critically. The study that some people cite as having worse outcomes with higher obesity rates is this UNO study that looked at patients over a 20-year period starting in 1987. This looked at recipients with a BMI greater than 40 and compared them to people with a BMI less than 40 and found that there was a little bit higher mortality. Although actually the odds ratio was about 1.18. So I find it interesting that people use this as a reason to not include that entire group of patients with a BMI greater than 40, when we certainly transplant people with much higher odds ratios of mortality than we do for this. And interestingly, they found no change in death from graft loss, cardiovascular disease, or cerebral vascular disease, which is what people I think would typically associate with obesity. This was later looked at and corrected for fluid overload and ascites, and they actually found that this did not hold true anymore. There's actually a lot better data out now that's a lot more recent. So 3 of the UNOS studies, which you see is our United Network for Organ Sharing. So it looks at all cases throughout the United States, found no difference in survival. So the first one here, published in 2015, looks at 2002 to 2011, more than 45,000 patients, and really just looking at 1-year survival. So are people dying in the perioperative period or immediately afterwards when we have the most complications? This was initially thought to be when patients with these rather large BMIs would be doing the worst. And they actually found that there was no difference, that the only BMI category that was associated with inferior survival was this underweight category. This next study, published in 2016, looked at the data that was published before, so BMI less than, or sorry, before 2007, and we looked at actually lower survival rates as was reported in that other paper, again looking at a hazard ratio of only 1.18 for mortality. But when they looked at all of the data in UNOS and SRTR after 2007, they actually found there was comparable survival. So this may be changes in immune suppression that we use over that time, changes in surgical technique, but that even looking at the one reasonable study that actually showed increased mortality, this does not seem to be the case looking past 2007. And none of this was corrected for ascites or other things. This is looking at BMI the same way that transplant centers look at BMI. These studies also showed that in patients with a BMI over 40 who underwent liver transplant, it dramatically decreased their absolute ARR risk of death versus being on the wait list. Absolute risk reduction. So a 95% decrease in absolute risk reduction if they got transplanted instead of remained on the wait list. So we know that we are not doing patients harm by doing this. It really saves their lives just as much or more than anyone else. When we looked at benefit from liver transplant, there was actually 88% decrease in mortality for patients with a BMI over 40 compared to 80% decrease in mortality for patients with a normal weight. So this brings us to the UW transplant experience. So there's actually quite a bit of data that we have out of here. As all of you are probably aware, we're a very progressive transplant center. We're known in particular for giving people the opportunity who have alcoholic liver disease to be a candidate for transplant. This was kind of ubiquitous throughout transplant centers that people had this 6-month wait to be listed for transplant after discontinuing alcohol use and led to death of a lot of patients. This is changing throughout the country, but we were one of the leaders in looking at this and looking at outcomes to see if this was a rule that actually made sense and made a difference in outcomes for patients. What we're seeing now is a similar thing with obesity. So a lot of centers are excluding patients with a BMI greater than 40 without looking at comorbidities, without really even evaluating them. And so we were one of the first people to publish a single center study saying that actually these patients tend to do well. So from 1997 to 2008, we looked at basically all patients with a BMI over 40, as well as all other BMI classes. This is the largest center, single center study looking at these higher BMI rates, and found that there was no difference in graft loss or patient survival at 1 year, 3 years, or 5 years. Interestingly, this was a little bit different population than what we have now. This was in the hepatitis C era. So if you look at the groups of hepatitis C and alcoholic liver disease, they certainly make up the biggest pieces of the pie. If you look at steatohepatitis and cryptogenic cirrhosis, which really are NASH and NAFLD patients, it was a much smaller proportion than what we see currently. If you look here, patient survival ended up being equivalent as well as graft survival. But you see after about 6 years that these kind of diverge, not really because they're different, but because there was a much smaller population in these higher BMI categories. So since then, Dr. Daniel, Dr. House and I have looked at UW data for a more contemporary study. So why look at another study for the single center? Well, we actually have data over 23 years instead of 11 years, where we have a very robust number of patients with this higher BMI category. So over 1,600 patients that we've done transplants on. Not me personally, but our transplant center has done a transplant in. For BMI 35 to 40, more than twice as many patients fall into this category, 168. In our BMI greater than 40 category, we have 107 patients in this more contemporary study, including 15 with a BMI over 50. This is kind of unprecedented for any single center study. In fact, the study that was published more than 10 years ago was actually, continues to be the largest single center study that's out there, and this is more than twice the size. And our population is very different over the last 10 years. So again, this is the rise of NAFLD and the fall of hepatitis C. And so is this the same outcomes that we're seeing in the NAFLD era? So we find that a lot of it is actually the same. This is looking at kind of a graph of where we fall with our BMI categories. We found in our study, as well as the previous UW study and many others, that wait time is significantly higher for obese patients, and that patients are more likely to die on the wait list. We also found that they're less likely to receive MELD exception points, which has been the same shown in other studies. We also found that the number of readmissions, the length of stay in the ICU, and the time from transplant to discharge are all longer for patients with higher BMI groups. We found that surgical time, vent time, cold ischemic time were actually all the same. And then graft survival, we found, is not lower. So actually this BMI 40 to 50 is the red line that you see on the top with the star, and the outcomes are actually excellent. This one that you find in the bottom, the purple, is BMI greater than 50, which trended towards being significant, although the p-value was still greater than 0.05. And you see this kind of drop off around 5 years, which is at least in part related to this being a smaller number. But if you look at the rest of this, this is outcomes going out to 25 years post-transplant, and we have a rather robust amount of data in this BMI 40 to 50 category. We found that older age of the donor actually was associated with worse outcomes, but that recipient age, race, and gender were not significant for graft survival. So this is the curve for patient survival. And again, we see that this is excellent in patients with a BMI of 40 to 50. And very similar things that found significance in our outcomes here. So this is really important because we are kind of the model of what happens when you have a center that does not have any BMI cutoff. We do not use a BMI cutoff of 40 and really just take into account the patient's risk factors when we're looking at transplant. Obviously, this group is cherry-picked for relatively healthy decompensated cirrhotic patients. So obviously that's a small group. But we find that this is very possible to transplant patients with high BMIs and have excellent outcomes and be able to open that up to the entire population, which is obviously becoming a little bit more obese. So the last part I'll talk about is weight loss in the liver transplant population. We'll go through pre-liver transplant, post-liver transplant, and then the type and timing of bariatric surgery. So weight loss in the pre-liver transplant population is complicated. So we really need to split this into decompensated and compensated cirrhosis. So patients with decompensated cirrhosis, we really need to focus on nutrition and muscle mass retention. As you see the person on the side, all of you have taken care of patients like this with significant cachexia, muscle wasting. Very frequently see people with NAFLD, significant central adiposity, who have severe wasting of their extremities, temporal wasting, and frailty. And these are not patients that we should be trying to have lose weight. These patients go into starvation state very quickly. So as quickly as 4 hours, their body will sense that they are starving and start to break down muscle. So we actually recommend frequent small meals, and evening snacks have been actually shown to retain muscle mass in these patients and to work on retention of muscle through small exercises, being able to walk stairs. If people do try to work on weight loss in these populations, they increase the risk of sarcopenia, malnutrition, frailty, and even bone loss and fractures. And so for patients that you're taking care of that have decompensated cirrhosis, even if this is from NAFLD, we're really outside of that phase where we can focus on weight loss as an effective mean of treatment. This really needs to focus on retention, and we should not be decreasing calorie intake in these patients. People with compensated cirrhosis are a very different breed. We have a lot of patients who have cirrhosis prior to being listed for transplant, or hopefully even people that may be able to avoid transplant completely. And this is the group where we really want to look at weight loss programs and potentially bariatric surgery. So pre-transplant medical weight loss is something that's really been looked at, and this includes all of the patients with cirrhosis who may even be able to avoid transplant or earlier in the field. So there's been some studies on this multidisciplinary intensive weight loss programs. Both UCSF and Mayo Clinic have had programs looking at all patients with a BMI greater than 35 being referred for these intensive treatments. The one I'll talk about here is the Mayo Clinic that had 44 patients with a BMI greater than 35 listed during this time period. Median BMI was about 40. 84% of the patients were actually able to achieve a BMI less than 35, which was their goal, with this intensive weight loss program. And if you look, what does this look like? They did a restriction of calories to about 1,200 to 1,600 kilocalories a day. They had to take daily food diary, weigh in weekly, increase their activity gradually to about 40 minutes per day. And they were followed up in the transplant clinic by hepatology and nutrition every 3 to 6 months. So they didn't increase the frequency there, but just spent more time with each of these visits going through these things as well as reviewing these things as an outpatient over the phone to be sure that they're following these dietary restrictions. And so we find that this is effective. Again, 84% achieved weight loss within the goal range. But unfortunately, 60% of those patients gained weight to a BMI greater than 35 post-transplant. So we're still fighting against this post-transplant weight gain and metabolic syndrome as well as recurrent NAFLD. For patients who did not achieve a BMI less than 35 at the time of transplant, the intermittent sleeve gastrectomy, which we'll go through later. So when we look at the type of surgery that we can do pre-transplant, we need to take into consideration a couple things. So as I mentioned with the other study, sleeve gastrectomy is actually the preferred method in patients who may eventually undergo transplant. Roux-en-Y has difficult biliary access. Because of the roux, we are not able to access the biliary tree normally. And this has implications post-transplant for patients who have biliary strictures or other complications. We have found that there's an effect on medication absorption in this population. There may be increased weightless mortality in patients who have Roux-en-Y, in part related to poor absorption of nutrients and increased sarcopenia and frailty. And there's a question of this having faster progression of patients with alcoholic liver disease. So there's multiple studies that show patients with a Roux limb absorb alcohol faster. They have peaks of the alcohol level to a higher peak because of this fast absorption, and actually more rapid progression of their alcoholic liver disease. The other thing is it may actually be associated with their own complications and even fatty liver, part related to absorption of nutrients related to the Roux-en-Y. Gastric band, which you can see to the right, in general is considered a little less effective of a weight loss procedure. Less weight is lost, and we also have this risk of foreign body infection post-transplant for people who are on immune suppression. There's a question of whether bariatric procedures could be used in these patients, and is something that we're hoping to look at the University of Wisconsin, getting to patients early in the cirrhosis or advanced fibrosis period, since this has been overall shown to actually decrease risk of progression with NAFLD. So ideally, you can get to these patients before they develop portal hypertensive complications. So there's been a couple of studies looking at patients in the pre-transplant period or patients who potentially could not go to transplant, and bariatric surgery has shown reduction in progression, even reversal of fibrosis in NAFLD, as well as resolution of NAFLD. There are patients who can do poorly. Certainly anybody with decompensation, there's a dramatic increase in mortality with the procedure. One of the studies found that 16% of patients with decompensated cirrhosis died following bariatric procedure. We need to have caution using a Roux-en-Y in these patients, thinking about if they may go to transplant in the future. So on the right, here's the Roux-en-Y. And again, for the reasons that we talked about, as well as actually significant increase in mortality on the wait list. And this is people who've had a Roux-en-Y anytime during their disease. So this is something to think about if you're referring patients with NAFLD and fibrosis. If it seems like they may eventually need transplant, Roux-en-Y may not be the bariatric surgery of choice. Sleeve gastrectomy you see to the right. This is a less invasive procedure, tends to have fewer complications in this population. UCSF did a study where they looked at patients who were listed for transplant. The median MELD was much lower than what the average MELD is for listed patients. It was 10 to 13. All the patients had previously decompensated, but were recompensated with medications and had symptoms well controlled. And so these patients, there were 32 with a BMI over 40 that had already failed medical management, kind of like the Mayo Clinic study. They found at 6 months, patients had lost about a third of their excess body weight. Excuse me. And at 12 months, they had actually had about 50% reduction in their excess body weight. Excuse my voice, that's I'm losing. So this is successful. Overall, they found there was only one significant complication with a staple line leak. That patient unfortunately developed further complications and was not able to be transplanted. 88% they found were eligible for transplant. 3 were lost to follow-up, which means about a 10% loss to follow-up rate. This is something that may be beneficial not just on patients who are listed, but patients who are earlier in the cirrhosis timeline. The last thing here is bariatric surgery combined with liver transplant, and this sleeve gastrectomy post-transplant. So the people who are pioneering this is Dr. Julie Heimbach at Mayo Clinic. It is sleeve gastrectomy at the time of transplant. They've been doing that since 2006. They took all patients greater than 35 who had undergone that weight management program and failed to get below a BMI of 35. If you look, 50% of those patients had NAFLD. But interestingly, 50% of the patients didn't have NAFLD, meaning this obese population that we're dealing with is beyond just NAFLD patients. It's really affecting patients with all forms of liver disease. So the patients who did not lose weight were much more likely to be in the NAFLD group. So about 75% of the patients who did not achieve a weight of a BMI under 35 were NAFLD patients. 45 of these 29 of these underwent liver transplant and sleeve gastrectomy. Average BMI was 47, and again had fewer exception points. And patients who underwent this were much more likely to maintain weight loss post-transplant. They also had less metabolic syndrome, lower rates of hypertension, hyperlipidemia, and hepatic steatosis with de novo NAFLD. So this was actually very effective in treating a lot of the outcomes that we were interested in this post-transplant period. There was no survival difference. So here shows this kind of dramatic chart. So the blue line shows patients who had undergone this clinical or medical weight loss, had lost a significant amount of weight, and unfortunately post-transplant gained almost all of that weight back. Patients who underwent sleeve gastrectomy did not lose as much weight pre-transplant, but actually kept the weight off really well, and again had lower rates of metabolic syndrome, lower rates of recurrent or de novo NAFLD. So this may be something that we're able to use in the future. Here's an example here, a nice beautiful pink liver. That's the transplanted liver, and you can see the sleeve to the right. When we look at other bariatric surgeries in the post-transplant period, very small series. If we combine two of the biggest ones, there's still only 14 patients. And overall, fairly reasonable complication rates. So no deaths, no graft loss, no increase in acute rejection. Unfortunately, in the Roux-en-Y, a little bit higher rates of complications post-transplant. And again, we run into problems with malnutrition, absorption of medication issues, and inability to reach the biliary tree. So from here, we need to talk about, the complexity of weight loss in the liver transplant population really deserves special attention. So this is something that we need to be looking at our center as well as nationally. As we start to have better outcomes in transplant surgery and our perioperative outcomes, we really need to see how we can make these people do better long term. We're looking at if perioperative bariatric surgery may be something that we're able to bring to UW, as well as trying to find out what patients could potentially benefit from sleeve gastrectomy or endoscopic bariatric management in the advanced fibrosis population. And then as Dr. Lucy had alluded to, we're hoping to expand this medical and surgical weight loss center at the American Transplant Center and include the perioperative, the listed transplant population, people post-transplant, and hopefully have more people be treated in this NAFLD group that could potentially avoid transplantation. So now, at the end of the talk, you should be aware that obesity is increasing in the listed transplant population, as well as recipients, and that does not just affect patients with NAFLD. We're really looking at the whole population. Understand that patients with obesity require special consideration in the pre, perioperative, and post-transplant periods. The BMI alone should not be used to exclude patients and is not used to exclude patients from our transplant center. So this should not be something that keeps you from sending them to us. And to recognize that our transplant outcomes for graft and patient survival with BMI 40 to 50 are excellent and not inferior to those with a normal BMI. Thank you, and I can take questions now.
So thank you, Dr. Spengler. It was an excellent overview. And I guess one benefit of doing our medical grand rounds remotely is we are decreasing the opportunities for donuts and muffins during medical grand rounds. So we're supporting trying to improve BMIs across our population. There is a question from Dr. Lucy about the effect of the prevalence of obesity and fatty liver on the donor liver pool. If you want to address that.
Yeah, that's an excellent question, and not one that I planted. Well, as we talked about, obesity rates are increasing dramatically in the entire population, up to almost 40%, which means all of our donors or potential donors obviously have much higher rates of obesity. So this has been overall a little bit less of an issue in our brain dead donors. In our deceased or ECD donors, which means patients who die from cardiac death, and we have a much shorter window to obtain the transplants. We find that a lot of those are not able to be used because of higher rates of steatosis, which confer worse outcomes at this point for transplant. And they've actually found for kind of all studies, and again, I kind of alluded to here, that donors with a higher BMI may actually have inferior outcomes for the recipient. We are looking at things to look at ex vivo perfusion, and we were involved with one of those studies where we actually actually perfuse the liver out of the body, and that's actually been shown to improve steatosis in these donated livers and maybe something that will broaden the donor pool. This also comes into play with living donation. That unfortunately a common reason for us to decline people for living donation is because they have significant steatosis themselves related to weight gain.
Great. And then from Nadia Sweet, with regard to the the recent study that you presented, what characteristics made patients in the 40 to 50 BMI category good candidates for liver transplant?
Yeah, so that's a good question. So obviously with any retrospective study, we're already selecting the patients prior to getting any data. So all these are selected in our listing meeting. So one of the big things is we really look at metabolic complications. We want diabetes to be well controlled prior to transplant. People who have really high A1Cs, we suspect will do worse post-transplant, as that tends to get worse as they're on immune suppression regimens. We look at really strict cardiac testing. We don't have a BMI cutoff to recommend a left heart cath, but these patients will fall into higher risk more often and are more likely to be excluded related to cardiac comorbidities. So we actually put them through the same rigor that we do everyone else, but it means that this tends to be a selected down population that are actually undergoing transplant.
So refer all the patients first, and then you will do the weeding out.
Exactly.
So to speak. Great. From Bennett Vogelman, how does volume of drug distribution in obese patients affect dosing, monitoring, and outcomes? I'm assuming this in the immunosuppressive regimen.
Right. That's a good question. There's been a fair number of studies on this. They have found that there's not a way to calculate the amount that somebody will need based on BMI. So none of these are actually weight-based doses. Most of our main immune suppressive drugs, particularly tacrolimus, we actually base on trough levels. And so we aim for actually the same trough level. We may need to use higher doses, but BMI alone is not actually very helpful at predicting how it's going to be metabolized and what the volume of distribution is. So again, we actually treat it the same way we would the rest of the population, which is picking kind of a starting dose and then monitoring for what the trough would be.
Okay, great. And then from Becca, I hope I get this, Walschlager, in terms of malnutrition and frailty in all BMI categories, what are your thoughts about implementing an early feeding protocol given the impacts on post-transplant outcomes?
Yeah, and so I'm guessing she means early feeding post-transplant. I don't know if she can kind of address both. So in the pre-transplant period, patients have a lot of frailty and malnutrition, and this is just as prevalent in the obese population. There's been questions about whether some of these patients should undergo even tube feedings prior to transplant to help with their frailty. In the post-transplant period, if she's talking about early refeeding, most things looking at non-transplant patients have shown improvement in frailty by doing early feeding after surgery. So this has been done with a lot of different groups. I'm not aware of any that have been done particularly in the obese transplant population, but I suspect that that may be something that decreases further muscle loss.
Great. And then I will take the chair's prerogative for the last question. And you may not know the answer, but I'm wondering how generalizable do you think your findings are for high BMI in other organ transplants? I know, for example, lung transplant, most places also have a BMI cutoff. So your thoughts on that?
Yeah, that's really interesting. We're hoping for ATC this next year to do a more general obesity panel so that we can have people from different specialties talking about how obesity impacts their organ transplantation. We deal a fair amount with the renal transplant population because it kind of overlaps ours. And I know we do use a BMI cutoff for that group, but I don't know what the outcomes are overall. For other things like cardiac and lung transplant, I certainly know less about those groups since we don't interact with those transplant teams or patients nearly as often. But I think it's a really important question that people should be asking.
Great. Well, I want to thank you very much, Erin, for setting up your studio at home for us. I want to also really give a plug and kudos to Clint Thayer for making this happen and allowing us to continue our medical grand rounds. And thank all of you for spending an hour talking about non-COVID related issues. It's been a delight. I will end on time and thank you again. See you next week.
Great, thank you.